Okay, good morning, good afternoon, everybody. It's my pleasure to share this ERS webinar on the ERS statement on chronic thromboembolic pulmonary hypertension. This ERS statement was recently published in the European Respiratory Journal in 2021. It consists of a review of literature of current practice concerning diagnosis management of chronic thromboembolic pulmonary hypertension. And this seminar include many task force participants distributed into many task force, 11, and we have also the help of the two people from the ERS office. What is the format of this webinar? First of all, it is a summary of statement with two speakers, Professor Marion Delcroix from Belgium on definition, diagnosis, epidemiology, and physiopathology of CTEPH. I have no control of the slide, I'm sorry, but I don't. And the second speaker is a Professor Eckhard Meyer, surgeon, professor in Germany, on the different modality of treatment, pulmonary endarterectomy, pulmonary angioplasty, and medical therapy, as well as multimodality treatment today. Now it's my pleasure to introduce the first speaker, Marion Delcroix, to start his presentation on his topic.
Okay, thank you very much, Gerald. So here are my disclosure. And I want first to introduce you to this publication landscape on chronic thromboembolic pulmonary hypertension. So we first have the proceeding from the World Symposium in 2019 on chronic thromboembolic pulmonary hypertension. We have also information from the ESC guidelines for pulmonary embolism published in the European Heart Journal and in the European Respiratory Journal. We have also a Canadian clinical practice guidelines on the diagnosis of chronic thromboembolic pulmonary hypertension published in 2019. We have our statements that you will see today. And we have also a bit later, published in 2021, the position paper from the Fleischner Society on the imaging of pulmonary hypertension in adults. And so here we have the start with the clinical classification of pulmonary hypertension, where you see that chronic thromboembolic pulmonary hypertension represents the fourth group of the different causes of pulmonary hypertension. Now, it is defined, of course, in patients who are symptoms, exercise dyspnea, by an increased mean pressure, which was initially 25 millimeters of mercury with a wedge pressure of less than 15, and recently amended to a low value of 20 with a pulmonary resistance of more than 3 Wood units. We have to have mismatched perfusion defects at the VQ scan. Also, specific signs of organized fibrotic clots on the CT pulmonary angiography or digital subtraction angiography, and this after at least 3 months of anticoagulation. We have also a population of patients who have same symptoms and same anomalies, but who have no pulmonary hypertension at rest. And we had until now not a consensus on the name for this entity, and also not a consensus for the name of the overarching disease. And that's why I ask you, what is your preferred term for patients in whom symptoms can be attributed to post-thrombotic deposits within pulmonary arteries? Is it chronic thromboembolic pulmonary hypertension, CTEPH? Is it chronic thromboembolic pulmonary disease, CTPD? Is it chronic thromboembolic disease, CTED? Is it chronic thromboembolic pulmonary vasculopathy? Or is it chronic pulmonary embolism? Please vote. So we have the majority speaking about chronic thromboembolic pulmonary hypertension, okay, but this doesn't include the entity without pulmonary hypertension. And that's why we move to the other terminology. So all patient symptoms can be attributed to post-thrombotic deposits within pulmonary arteries could be considered to have chronic thromboembolic pulmonary disease with or without pulmonary hypertension. And chronic thromboembolic pulmonary hypertension remains the preferred term in patients with pulmonary hypertension. Now here you see then the results. So we have on the right side the CTPD patients without pulmonary hypertension and this chronic thromboembolic pulmonary disease at the overarching terms, including also the patient with pulmonary hypertension. So now the second point that I want to emphasize is that cardiopulmonary exercise and exercise tri-heart catheterization can contribute to the definition in CTPD, helping to identify the main cause of exercise limitation in the presence of comorbidities and in patients without resting pulmonary hypertension. Finally, the disease, is it curable? In many patients with CTEPH, resting mean pulmonary arterial pressure is normalized by surgical or multi-modality treatment, as you will see in the next part, and patients feel healthy. But it is unlikely that, that all patients are back to normal. So now my second question, what is your preferred imaging technique to identify CTEPH? So a planar VQ scan, a single photon emission computed tomography, a CT pulmonary angiography, a dual energy CT, or digital subtraction angiography. Please vote. Okay, so most of you think this is CT pulmonary angiography. We can have very nice imaging with CT, but I think the task force member had another opinion. Ventilation perfusion scintigraphy remains the most effective screening tool to exclude CTPD. And VQ single photon emission computed tomography, also called SPECT, has been shown to be superior to planar imaging and is the methodology of choice. But because the transition from planar to SPECT may not be easy for clinicians unfamiliar with the three-dimensional anatomy, two-dimensional planar imaging can be reprojected from SPECT without losing diagnostic accuracy. So you see here on the top, you see the planar VQ scan with the defects that you see here. And this is the SPECT picture where you see a more good separation between the perfused and non-perfused zones. And on the right side, you have the reconstruction planar from the SPECT for the perfusion and for the ventilation on the lower part. And you see when we compare both pictures, we see that the definition is even better when we have this reconstruction. So the next part is what is the place of the dual energy CT scan, which is an alternative perfusion technique. So it has theoretical advantage over the VQ because of a better availability, but also it has more technically challenging in the sense that you have to have a right timing. It has limited availability. Not all centers have this, and it lacks multi-center validation. So this is currently not replacing VQ in the clinical practice. So now we move to the CT scan. CT pulmonary angiography is adequate for the diagnosis of proximal CTEPH, but the negative CT, even if high quality, does not exclude CTEPH, as distal disease can be missed. So you see here proximal disease, that's not a problem. But when you move to the segmental arteries, it's more difficult. And so here we have now additional technique like the cone beam CT, which allow for better visualization of the subsegmental vasculature and have been shown to be useful for procedural guidance for balloon pulmonary angioplasty. However, it requires validation in prospective trial. It's also needing a lot of X-ray exposition. But what you see here, even better than the digital subtraction angiography, you'll see that there are webs and slits which are visible here. I think the picture has been moved a bit, but you have these webs and split as the pathology samples. Now, this is the current algorithm proposed by the task force members. You have pH suspected, you have the echocardiography. If pH is possible, pulmonary hypertension is possible, you do VQ scan, preferably with SPECT. If it is normal, you exclude the group 4 pulmonary hypertension. If it is abnormal, you do a CT. If the CT is high quality, proximal CTEPH is confirmed, then you can stop there. If it is negative, CTEPH is not excluded, and so you go for a pulmonary digital subtraction angiography. If the technique is suboptimal, then you go for this angiography also. And in some centers, MR pulmonary angiography can be performed in order to, if they have sufficient experience and specialize with this technique. So concerning now the epidemiology of CTEPH, which proposition is not true according to you? CTEPH is usually considered as a complication of acute PE. 50 to 75% of the CTEPH patients have a history of CTEPH. At the time of the acute PE, a majority of CTEPH patients have already signs of CTEPH on echocardiography and CTPA. And finally, the cumulative incidence of CTEPH after acute PE averaged 10%. Please vote. Okay, so most of you think that CTEPH occurs in 10% of the CTEPH. We will see that this is a too large figure. And I lost my pointer here. Okay, so we will be in detail. I think the 3 first propositions were correct anyway. And this is what you have here. This is the figures which has come out, meta-analysis, including 16 studies in 4,000 PE patients. And you see that the proportion is 3% incidence of CTEPH in the survivor of PE. And this is already a high figure. Some studies with proven diagnosis by right heart catheterization show lower figures. So CTEPH is a rare and underdiagnosed complication of PE. And upon first presentation may be misclassified as acute PE. And how do we recognize that? First, by echo. You see here a picture who are showing you a right ventricle hypertrophy. However, it's a bit difficult to measure. And another sign which is very important is the level of the pressure. So you have here the tricuspid regurgitation pressure gradient to measure the pulmonary arterial pressure, which is generally lower than 60 when the right ventricle is not remodeled. I don't know if the team from the ERS can stop to move the slides or to have this automatic moving of slides, because it's a bit contradicting. So now we have also the radiology to differentiate acute from chronic PE. We have here a picture from acute PE, the central polyamine sign, which showed that the clot is in the middle and the contrast is around. And then you have a railway track sign, which is here, and which is showing again that the clot is in the middle. And then you have here eccentric material sometimes, but which is having acute angles with the vessel wall. At the opposite, when you have chronic thromboembolic pulmonary hypertension, you see here that you have a material which contains sometimes calcification. You have this material which is lying the wall, but which obtuse angled. And you have something which is very important, the retraction of the organized thrombus. You see, when a thrombus is fresh, it takes all the lumen and the vessel is even larger. But when it's chronic, it's becoming very fine. Now, when we put together the signs suggesting CTEPH, so you have here data from the study showing that you have to look at signs of an echo and CT before you can exclude CTEPH in the acute circumstances. So in the 7 patients that there were with CTEPH in this cohort, a large cohort from France, you see then when you combine 2 signs, CT, organized mural thrombi, arterial webs and bands, dilated bronchial arteries of mosaic of parenchymal perfusion, you recognize, you identify nearly all the patients with CTEPH in this cohort, and it's much less frequent in patients with only acute PE. So persistent perfusion defects after acute PE, in fact, are common, and they have variable clinical relevance ranging from completely asymptomatic patients for the majority of them to established CTEPH. Also something important in these patients with persistent defects is we have no evidence to suggest that CTPD without pulmonary hypertension is an early stage of CTEPH because we have a complete lack of data on the natural history of these patients with persistent perfusion defects. Now, my 4th part is the follow-up after acute PE. So earlier diagnosis of CTEPH may be relevant for patient outcomes. It can be achieved by targeting patients with acute PE with risk factors for CTEPH or with radiologic findings suggesting CTEPH. And we have seen how these radiologic signs are. So patients at risk can be identified with accurate diagnosis by the CT images. Sorry, I'm not yet there. Can you wait with the poll? Can you move the poll out, please? Okay, you cannot, it seems. Okay, thank you. So the patient at risk of CTEPH can be identified by these CT images and also in the presence of individual risk factors for CTEPH. In the context of symptoms of functional limitation of right heart failure. And so among these risk factors, next slide, yes, which of these conditions is not a risk factor for CTEPH? A non-O blood group, a longer duration of time from symptoms to acute PE, a factor V Leiden mutation, a splenectomy, a ventricular atrial shunt, or chronic inflammation. Please vote. Okay, so you think that non-O blood group is not a risk factors. So we will look now, and a few of you think that factor of Leiden is not a mutation. So here we have a table summarizing these risk factors. So here you see the reported odds ratio when you compare CTEPH with idiopathic PH and then the estimated prevalence among patients with acute PE. So you see one of the most important factor, for example, is the V shunt, 76 higher risk of doing CTEPH, and splenectomy, 18 times more risk of having CTEPH. But these 2 entities are very poorly represented in patients with acute PE. However, non-O blood groups is something which is doubling the risk of having CTEPH, and it is frequently distributed in PE patients, and this is much more than in the normal population, so it is important to look at. Something which is underrepresented in patients with CTEPH in comparison with PE patients is this factor V Leiden. So it's really not a risk factor for CTEPH. Now, when we have these suspicion, risk factors, and CT images, the echography is a test of choice in patients with suspected CTEPH. Other tests can be used, a Leiden CTEPH rule-out criteria that you can find in Eric Klok publication, the VQ scan, or the cardiopulmonary exercise test can be used to exclude the presence of CTEPH or to recognize alternative diagnosis. So now, what is the optimal timing for considering CTEPH in patients with PE? Is it 1 month, 3 months, 6 months, 2 years? So please vote. Three months, and then I think everybody can agree 3 to 6 months looks like a very good window. And this is also the recommendation of the ESC guidelines for acute PE. They recommend the clinical evaluation of patients with acute PE at 3 to 6 months. This is something which is new in the guidelines and very important, and it is a class 1 recommendation, so very important to look at that. And in symptomatic patients, again, very important to ask the patient he has restored after acute PE. When you see mismatched perfusion defects in a CT scan after 3 months, and the patient is symptomatic, you can send him to a chronic thromboembolic pulmonary hypertension center in order to look what can help him. So the optimal timing, considering CTEPH in patients with PE, is the routine 3-month follow-up visit, but earlier workup may be necessary in highly symptomatic patients or patients who deteriorate and have signs of right heart failure. And the pathophysiology is the last item in this presentation. So the current knowledge suggests that 2 types of vascular lesion exist in CTEPH. The proximal fibrotic obstruction in large elastic pulmonary arteries, as you see here, and the secondary microvasculopathy in pulmonary vessels, which are smaller than 500 micrometers. So I'm sorry, my slide has again moved a bit. You see here that you have this fibrotic material, which is unresolving. And when you have the zones who are not occluded, they are exposed to high pressure and flow and vasoactive factors. And that means that with time, small vessel arteriopathy is developing in this open zone with lesions which are very similar to what you see in idiopathic PH with that dead tree aspect in the region which is still open. Here you have the occlusion of the lower lobe of the left lung. Beside that, in the open lung, we have also problem in the occluded region of the lungs because of the systemic bronchial collateral circulation, which is making some connection with the pulmonary arteries, so the blue pulmonary arteries with blue blood, and also connection with the pulmonary veins, leading to a remodeling and progressive occlusion of the arterial and venous side of the pulmonary circulation. And you see here this bronchial circulation, which is coming from the descending aorta, from the intercostal arteries, and also from the subdiaphragmatic arteries. And so what you will also find in the statement is a survey of VQ SPECT, DECT, and MR used for CTEPH in expert center, a description of what makes a high quality CT pulmonary angiography, and sorry, I'm losing control. Also a comparison of the CT feature between acute PE and CTEPH. And now I'm transmitting the word to my colleague, Professor Eckhard Meyer, who will speak about treatment. Thank you for your attention.
Thank you, Marianne. Thank you, Gerald. Good afternoon, everybody. It's a pleasure that so many colleagues are interested in the management of CTEPH. These are my conflicts of interest. And I need...
Please click on the screen once, and then you can move, please.
That's what I did.
Click on the screen with
Yes.
your mouse. Click, please. Yeah.
Okay, thank you. So before we talk about CTEPH treatment options in something is wrong, it's running by itself. So before we talk about treatment options in 2021, we should go back for 10 years. And in the 2009 guidelines of ERS ESC, there was only one recommendation for CTEPH treatment. This was surgical pulmonary endarterectomy. And there was some mild recommendation for off-label use of pH-targeted drugs. Now we are 10 years later, and we have quite a lot of CTEPH treatment options. We have still pulmonary endarterectomy, PEA, as the standard of treatment, and PEA is possible now also for patients with distal, segmental, or subsegmental disease. We have a new or newly reinvented interventional technique, which is balloon pulmonary angioplasty. We have two drugs that have been approved for CTEPH treatment, and it has been shown that rehabilitation programs are very useful for inoperable patients or for patients after interventional treatment. And we can, meanwhile, combine all those modalities. We have another treatment modality at the horizon in the pipeline. This is pulmonary artery denervation, but there's so far only one publication, and I will not talk about that at the moment. So this is our current treatment algorithm from the 2018 World Symposium on Pulmonary Hypertension. So whenever the patient has the diagnosis of CTEPH, the patient needs a lifelong anticoagulation and a treatment assessment by an expert CTEPH team, which means PH specialists, interventionalists, PA radiologists, and surgeons. And it has to be evaluated if the patient is operable, and if yes, pulmonary endarterectomy is still the treatment of choice. This is approximately 2/3 of the patients. If the patient is non-operable, we now have targeted medical therapy and BPA, and we can combine those two options. And this is approximately 1/3 of the patients. So if you look at the anatomy of the pulmonary arteries, you can see here the main pulmonary artery, lobar arteries, segmental arteries, subsegmental arteries, and microvasculature. And you can see here the treatment options. So PEA is the treatment of choice for obstructions down to the segmental and subsegmental level. There is some overlap with BPA, and it's clear that medical treatment is only effective in distal microvasculopathy. This is the concept of PEA surgery, or this is a very complex operation, but it's very well standardized. It has been developed by the colleagues from the University of California in San Diego, but there is significant experience in Europe now since approximately 30 years. We always need extracorporeal circulation. We always need phases of deep hypothermic circulatory arrest at 18 or 20 degrees body temperature. And within those phases of hypothermic circulatory arrest, bilateral endarterectomy is performed down to the segmental and subsegmental level of both lungs. Here you can see this nice figure. This is the incision in the right pulmonary artery with the so-called Daly or Jamieson sucker put down into the right lower lobe arteries for dissection between the fibrous tissue and the vascular wall. And if you are successful, you will receive such a kind of specimen. This was a young patient with exclusive perfusion of the right upper lobe. Every other segmental arteries were completely occluded or stenosed. Here, right middle lobe and lower lobe, left upper lobe, left lower lobe. So this is a complete removal of the obstructive material. If you look at results, this is data from the first European CTEPH registry that has been published by Professor Delcroix in Circulation 2016. You can see that late survival is different in the operated group. This is the red curve. Compared to the non-operated group, there is a significant difference after 3 or 4 years. And survival is very favorable in the operated group. There will be a new registry, including data from BPA in the near future. And we are really interested in how the curves will be looked if we include BPA in such a registry. If you look at quality of life, which is a main point for this individual patient, you can find here some very good data from the Cambridge group published in Lancet 10 years ago. And it has been shown that quality of life can be brought back to normal despite the use of circulatory arrest with no neurocognitive function deficit or something like that at 3 months or 1 year after surgery. So it's a safe operation. The task force, the ERS task force, has therefore concluded that the requirements for a PE center are based on expert opinion only, but at least 50 cases should be the annual volume of a center, and at least one properly trained surgeon needs to be there for a high quality PEA center. There is overlap between BPA and PEA, but segmental and also subsegmental disease are suitable for surgery in highly experienced centers. Successful outcome after PEA is multifactorial, and we should have an in-hospital mortality of much less than 5%, maybe only 2%, survival of at least 90% at 3 years, with an improved clinical status and quality of life of each individual patient. However, we do have some residual pulmonary hypertension of PEA that might be present in up to 50% of the patients, and those patients have to be strictly followed up, and because they can be in addition treated by medical treatment and or BPA. So this is my first patient, 39-year-old female in functional class 3, with a PVR of 6 Wood units. This is significant pulmonary hypertension. She came from another country and was already put on riociguat in November 2017. This is the angiography showing distal, segmental, and first-line subsegmental obstructions on the right pulmonary artery, and also especially on the lower lobe of the left pulmonary artery. So this is my first question. What is your treatment recommendation? Would you increase the medical treatment and do a CTEPH targeted combination therapy? Would you recommend surgical treatment despite the high risk due to distal disease? Would you recommend BPA in a young patient where you do not really know the long-term results? Or would you even evaluate the patient for lung transplantation? Please vote now. Okay, so most of you would try to treat that mechanical problem with a targeted combination therapy. Some of you are very brave and would go for PEA in a very distal case. And some of you would go for BPA and only a few for lung transplantation. Okay. So we were not really brave because This case is really too distal. If you look at the angiography, most of the obstructions are there, but you cannot treat them by PEA because it's too distal. On the other hand, it's clear mechanical, and you cannot really clear that mechanical problem by combination therapy. So this patient underwent BPA, and I will show you the effects later. So I have a second case which is similar, 26-year-old male who presented with progressive dyspnea without any acute event. He was diagnosed with distal CTEPH and functional class 3 in January 2017, already very impaired pulmonary hemodynamics. He was considered inoperable, and there was a rapid clinical deterioration, and therefore he was started to get treated with riociguat and transferred to our center in May 2017 for the discussion of PEA versus BPA, or PEA combined with BPA versus lung transplantation. At that time, he was already in function class 4 with a very, very poor right ventricular function. So this was the angiogram, and it's very similar to the first case. You can see distal segmental and first-line subsegmental obstructions here, right AP, right lateral or projection, but also in the left lower lobe. You can see that very nicely that it's very distal disease. And if you look in detail, this is left lower lobe artery. You can even see the obstructive material here in the distal subsegmental arteries of the left lower lobe. So again, what is your treatment recommendation? Medical combination therapy, again, high-risk surgery with a very high risk due to high PVR and distal disease. Would you bring a 26-year-old patient to BPA, where we do not have very good long-term results at the moment? Would you try to combine BPA and PEA, or would you go for lung transplantation due to very rapid deterioration? So vote now. Okay, so I think the hybrid or combination of PEA and BPA would be the concept that most of you prefer. And this was also what we discussed. We also discussed lung transplantation and in combination with improved medical therapy, with combination medical therapy. However, when we spoke to the patient and his family, he did not really go for lung transplantation, and we decided for high-risk surgery and staged BPA if necessary. So the patient was operated on 29th of May 2017. It took 3 phases of deep hypothermic circulatory arrest, summarized to 48 minutes at 18 degrees. This is the specimen that could be removed. And again, you see the obstructive material in the subsegmental arteries that I have shown you before in the pulmonary angiography in virtually all branches of the right lung, and we missed some of the arteries of the left lower lobe. However, 3 years after surgery, the patient came back in function class 1, no pulmonary hypertension, no medical treatment, no BPA. So this was a very critical and helpful decision for this patient. This is the concept of balloon pulmonary angioplasty. This concept had been evaluated by groups in North America and in Europe 20 years ago, and it was stopped due to severe complications. And later on, colleagues from Japan reinvented and refined the whole concept with their techniques. And this here you can see such a distal segmental web lesion, here the angiography, and a catheter is passed, a wire is passed through this web lesion. A balloon is put into the web lesion over the wire and then inflated. Here you can see the cross-section of the artery. This is before the intervention. You see the web lesion with fibrous tissue, the balloon in the web lesion, inflated balloon, and this is the result. The fibrotic tissue is disrupted and pressed into the vascular wall, but in contrast to the operation, it stays in the vessel. So it's a different concept. And if you look at results, we can state that we have improving results with BPA. These are many studies from different groups. Most of the groups are from Japan, and some from North America and from Europe. And what you can see that approximately 3/4 of the patients had been pre-treated medically, and there was a significant effect on PVR, a reduction of 55% of PVR. And you can also see that the results were much better in Japanese series compared to European series. And what you also can see here, that it's a dangerous intervention. It's not so easy. 29% had some kind of lung injury, and the early mortality was close to 2%. That's close to surgical mortality. So it's not an easy not an easy intervention. If you look here at the French series from Professor Simoneau's group, this is the largest series outside Japan with excellent short-term results. And the most important thing of this publication from the European Respiratory Journal is that there is a significant learning curve with regard to complications and outcome. The more operations or the more interventions that are done, or the better is the outcome and the lower is the risk of complications. So the group has stated that inoperable CTEPH patients can benefit from BPA, and this has to be decided by a multidisciplinary team. Long-term results are still scarce, but they are available out to 8 years after the intervention. And the learning curve is, like in surgery, impressive. Proper training in high volume center is critical for BPA, like in pulmonary endarterectomy surgery. So this is the case that I showed you before, that many of you wanted to treat with combination therapy. And if you look here, this is a right lower lobe artery of that patient. You can see the complete obstructions in the 2 subsegmental arteries before and after intervention, and you can see the improved parenchymal perfusion and the venous return to the heart. This was right lower lobe. I will not show you all the interventions. This is right middle lobe, poor perfusion in segmental artery number 5, and improved perfusion after BPA. And this patient had 6 BPA sessions, and 6 months after the last session, she was significantly improved clinically and also hemodynamically. This is not cure, but it's significant improvement. So the third option is medical treatment, and it is clear that all patients should undergo lifelong anticoagulation. And many of the patients, meanwhile, are anticoagulated by NOACs. And it has to be stated that antiphospholipid syndrome is a contraindication to NOACs. Those patients need vitamin K antagonists. We have 2 drugs, riociguat, an oral drug, and treprostinil, a subcutaneous prostacyclin analog, that are approved for patients with inoperable CTEPH or CTEPH after or successful or PEA or BPA. Oral combination therapy is a common practice in CTEPH patients with severe hemodynamic compromise. This is off-label therapy. How can we combine therapeutical options? We can combine in every way. We can combine the interventional procedures, PEA and BPA, as hybrid or staged. We can start with medical therapy and combine with BPA. There will be an interesting results of the so-called RACE study from Paris, where medical versus BPA was tested with a crossover option. Maybe Professor Simoneau will tell you the preliminary results. And we have also some data on medical combination therapy in the MERIT study. So the conclusion of the task force was that patient selection for multimodal therapy is performed again in expert centers by multidisciplinary teams. There is no convincing evidence that preoperative drug treatment is beneficial in patients with operable CTEPH, and additional BPA after surgery is very useful for patients with persistent pulmonary hypertension after surgery. And most task force members stated that they use CTPH targeted drugs prior to BPA to improve the safety of BPA. We can talk about that later. So this is my last point. Rehabilitation programs like in PAH seem to be very effective and safe in inoperable CTEPH patients, and also carefully monitored low-dose rehabilitation programs are useful in patients after PEA or BPA, and this is becoming more and more the standard of care. So this is my last slide. Many of you know that CTEPH conference was planned for June 2020. We had to postpone it due to the pandemic to June 2021. And at the moment, we are still discussing if we will have this meeting in Bad Nauheim in Germany really in June, and it would be a virtual meeting, or if we postpone it to November 2021, where many of you will be able to, hopefully able to travel again, and many of us will be able to travel again, and we would be very happy to meet you all there in Bad Nauheim. You can check our website, cteph2021.org, and you will find the exact date and information on the meeting next week. Thank you.
Thanks a lot. Now we have to answer some questions. And we have a first question for Eckhard Meyer. You have to put your, okay. Is PEA endarterectomy? I'm sorry, the question has disappeared. The system is not perfect, huh? I don't find the first question now. Is it possible to help us for the question? It will be nice.
Yeah, Professor Simoneau, you need to scroll up because there are new messages coming, and you scroll up to find the question from the chat.
One first question is for Marion or for Eckhart. Do you suggest bosentan or macitentan when in country we see what is not available?
So I think I can reply to that with bosentan. Indeed, is the most available. Also sildenafil. There has been for CTEPH in a very small trial, which was not significant improving patients. We have for bosentan also a more randomized control trial showing that there was a significant improvement in pulmonary resistance, but not in 6-minute walk. Anyway, all these drugs are used in patients where you don't have access to the riosigwat and have a load improved outcome in the patients who are not operable. But it's off-label use, but it's used also in combination therapy. You have riosigwat plus bosentan of macitentan is more difficult in most of the countries because it's not reimbursed for CTEPH.
I have another question for Eckhart Meyer. Probably I have to modify this question because is PA also an option for chronic pulmonary embolism? Probably it's meant to in chronic pulmonary disease without pulmonary hypertension. Eckhart?
Yes, so for patients with chronic obstructions of pulmonary arteries without pulmonary hypertension, where we can find a significant exercise limitation due to pulmonary artery obstructions, surgery is a possible option. However, we need to make very clear evaluation by exercise testing with CPET and exercise right heart catheter before. And if you see that there's exercise pulmonary hypertension and the patient is symptomatic, we will go for surgery. And if surgery is not an option, there is an increasing number of patients that are treated by BPA.
I have one question for Marion. Is there a correlation between the importance of acute PE and the occurrence of chronic thromboembolism?
Okay, thank you, Gerard. There is, in fact, in acute PE, we have a correlation between the size of the PE, the number of segments who are non-perfused, and the pulmonary hypertension. In CTEPH, we have a discordance because it depends from the number of vessels who have remodeling and the microvasculopathy. However, we see that in the CTEPH cohort, the patients with massive PE are overrepresented in opposition to the patients with acute PE. So if you have a life-threatening PE, you have more risk of having CTEPH afterwards. Also, the delay between the treatment and the first symptoms is also increasing the risk of the disease of CTEPH.
What is the best choice of anticoagulation in CTEPH relating to PHTN?
Good question.
Eckhart or Marion? Okay.
Okay, so we don't know, in fact. So we, a long time we recommended to use vitamin K antagonists because there we have a lot of historical data, but we see the practice changing with more and more patients having receiving the new oral anticoagulants. We have no signs that there are more patients, more complication, more recurrence on this treatment, but we have no real data. And so it depends a bit of the country. I think in Germany, Kat, you have a lot of patients on NOAC. We have more patients on vitamin K antagonists. Some patients need even to be on low molecular weight heparin for a long time because they are doing many recurrences.
We have another difficult question. How important is a lung function test for the diagnosis and management of CTEPH?
So I can answer. So one of the contraindications to surgery is having important COPD. I think Eckhart, you can perhaps say what are your limits of surgery if you have important COPD with impaired lung function.
So it's a difficult question, but if FEV1 is less than 40%, or you have to be very cautious with surgery. On the other hand, we do have some patients with significant emphysema in the upper lobe and in parallel occlusion of the lower lobe arteries. And those are the patients who might profit from surgery, but it's very clear the more significant the emphysema or COPD is, the highest the risk of surgery. But I would still say so those patients need an individual evaluation, and many of those patients have poor lung function tests because of technical problems or their problems to breathe.
Another question for Eckhart concerning BPA. Do you think it would be possible to use BPA as the only treatment by repeating the procedure several times over time to treat this patient?
I think it depends on the localization of pulmonary artery obstructions, and if all of the obstructions are located in the subsegmental arteries, BPA is a very, very good option. And it's also a good option to combine it with medical treatment.
We have two similar questions. Does BPA before pulmonary endarterectomy make it difficult to perform endarterectomy?
We think yes, because you interrupt the integrity of the vessel by BPA, and it might be very difficult to find the right dissection plane during surgery. So whenever possible, we avoid to operate on patients after BPA. There is a very limited number worldwide of patients that have been treated by PEA after BPA. This is a difficult question, and I would not recommend that.
Maybe, Eckhart, I can add some personal experience, because sometimes you have very severe patients, old patients, with a very distal disease in left-hand side, very proximal disease right-hand side. And what we perform in my department in Paris, Saclay University, is to start first with medical therapy to improve hemodynamics if the patient is very severe. The second time is to perform angioplasty in the very distal disease, non-operable, and to finish when the patient has a major improvement in hemodynamic on the right-hand side by endarterectomy. What do you think?
Yes, we are doing that in a similar way. In those patients, if there are severe hemodynamics, we would combine it in one hybrid procedure. That means do the operation on the right side, try the operation on the left side, and if not possible, do the BPA as a hybrid procedure in one intervention.
I have a question from my friend from Lisbon, from Porto, Abilio Reis. Do you see any inconvenience in using medical therapy while the patient is waiting for pulmonary endarterectomy?
We do believe that pre-treatment with CTEPH drugs makes the operation more difficult, but we do not know it. A randomized trial trying to solve that question had been started 3 years ago, and we had to stop it last year at the beginning of the COVID pandemic. So we do not really know how to answer that question. But in clinical life, in Germany at least, many of our patients with severe CTEPH are pre-treated by drugs, even if they are clearly operable.
We have another question on CTPD. Do you recommend the same modality of treatment in CTPD as compared to CTEPH?
I didn't understand your question.
The question is, do you consider the same modality of treatment for a patient with CTPD as compared to patient with CTEPH?
Yes, we do, but as I told you before, the evaluation of the patient has to be much more intense with regard to exercise testing.
Okay. In my experience, the major problem is the CTPD patient, because the CTPD patient in general is a young patient with very proximal occlusion of one side. And in this case, these patients are very symptomatic, and due to not only pulmonary hypertension on exercise, but also dead space increasing.
Yeah.
And probably this patient can benefit a lot from surgery. But for CTPD with only very distal lesion and microvasculopathy, I am not sure we can propose some treatment, and we need to have evaluation in this population not today evaluated.
Yes.
We have an interesting question on thrombolytic therapy. Can thrombolytic therapy reduce incidence of CTEPH?
So
after massive or submassive pulmonary embolism?
So we see in some of the study done to look which patient who has developed CTEPH after acute PE, there has been shown that having thrombolysis is a predictor of less CTEPH. However, in the large PHYTO study, which is a thrombolytic study, which looked also at patients at long term, there was no difference in the patients receiving thrombolysis and in the patients who were receiving placebo regarding the number of CTEPH patients. So we have evidence on both sides, but I think the PETO study is more demonstrative that it is probably not playing a real role.
Eckhart, we have a question on rehabilitation. Is there any structured rehabilitation program for CTEPH?
Is there any
structured program of rehabilitation well established?
There's 2 or 3 publications on rehabilitation in CTEPH patients from the University of Heidelberg. They have quite an experience, especially in patients after PEA with controlled training. And this has been published several years ago in Circulation.
We have a question for Marion and Eckhart. Which one to start as medical therapy, riociguat or treprostinil?
So we have a long experience with riociguat with very good results. It's easy to use. And treprostinil has just been, a few months ago, have been approved in Europe for the treatment of CTEPH patients. But you have to know it's a subcutaneous treprostinil. It's difficult to administrate. You need to have a good strategy to manage the side pain when you administer this subcutaneous prostacyclin. So I would certainly not use that as first line unless the patient is very sick.
I totally agree. In addition, there is a problem with the cost of the treatment, much higher with subcutaneous treprostinil. In addition, in some country in Europe, treprostinil is approved, but not today reimbursed, like in France or in Belgium and another country.
Yeah.
Okay. Alors, I have one question. For a young patient with 26 years old will respond well to PA. How long and frequently we need to follow up this patient for? What is the follow-up of young patient treated with endarterectomy and considered as normalized or almost normalized?
I think it's one word, it's lifelong.
Professor Simoneau, we need to close the session. We will collect these questions and send them to you, the unanswered one, and then we can post your responses on the website.
Okay, thank you. But now it's time to conclude this webinar of ERS on CTEPH statement. I think it was very active, a lot of questions, and we have a lot of work to resolve all these questions. Thank you so much, everybody.
Bye-bye, thank you.
Bye-bye.
Bye.